Hello, everybody. Welcome along to this talk. Now, the next talk we're going to have, and it's why you're gathered here, is on the subject of skin cancer and skin cancer prevention. And I'm delighted to welcome on stage Dr. Rupert Barry, consultant dermatologist at St. James's Hospital. And Dr. Barry's interest lies in the diagnosis, the management, and the clinical research around skin cancer. And he will be sharing his expert advice with you all today. So I'd like you to welcome Dr. Barry. I'd also like to add, which I'm sure Dr. Barry will be taking questions from anyone throughout this discussion at various points. So do feel free to ask those questions, and Dr. Barry would love to hear from you.
Thank you very much. Am I on there? Yeah? Yeah. Great. Okay. So firstly, thank you very much for coming in. And we're going to talk about not necessarily prevention of skin cancer, because the reality is we cannot prevent skin cancer entirely, but we can mitigate skin cancer. And that's really what we're going to talk about. So firstly, some conflicts of interest. I am a practicing dermatologist and a Mohs micrographic surgeon. So I have an inherent interest in this, both kind of dealing with it and also, from a career point of view, benefiting from it. I'm a non-executive director for the last 5-6 years of the Irish Skin Foundation. I'm a co-founder and shareholder in Dermview Limited, which is a teledermatology and dermatology services company. But I have no financial arrangements, associations, or relationships with any cosmeceutical or pharmaceutical company. So, how we're going to structure this talk is, I used to, as a kid, read a lot of magazines and a lot of comics. And then I was looking at my young little boys, and they were doing the same. And I always, they'd be, in the comic strip, there'd be kabam and crunch. And so I said, right, okay, what do we do? So we'll have a little acronym. So the acronym is kabam. Let's have knowledge of skin cancer, behavioral change. What can I do to reduce my risk of skin cancer? The awareness of your skin. How do I know if I possibly have a skin cancer? And then make an early appointment to see a doctor. What can I do if I think I have a skin cancer? So, skin cancer. What is it? What causes it? Who gets it? Is it common? And in Ireland, how are we faring compared to the rest of Europe and indeed the rest of the world? So, for this talk, I'm really just going to talk about the three main skin cancers. That's basal cell carcinoma, which is by far and away the most common, squamous cell carcinoma, and malignant melanoma. And between the three of those clinical entities, they make up approximately 90 to 95% of all the skin cancers that we as clinicians or you as patients encounter. The rest of them, atypical fibroxanthoma, Merkel cell, to be honest, they're the minutiae. We don't need to be concerned about them today. So what causes skin cancer? The vast and main etiological agent or cause for skin cancer is ultraviolet radiation exposure. Ultraviolet radiation exposure initiates changes in the DNA of our skin cells, when the DNA and the repair mechanisms for our DNA, because every day in all of us, in every cell, the DNA is potentially changing, and then we have our own repair mechanisms built in. It's a very elegant system, the human body. And there's repair mechanisms built in that then actually repair those mistakes in the DNA so that we don't produce abnormal proteins, and then we don't produce potentially abnormal clones of cells, which then develop their own blood supply, their own decision-making ability and autonomy, and then create a cancer. And that's how a cancer is formed, be it in your lung, your brain, your bowel, or your skin. And ultraviolet radiation, which is mainly of three different types, UVA, UVB, and UVC, are the main types of ultraviolet radiation and wavelength that come from the sun. Now, UVC is largely irrelevant to us, except at the poles of the Earth, which we don't live in, and also across maybe some of Australasia, where there is a hole in the ozone, because ozone is very effective at reflecting back UVC. And UVC is a total carcinogen. It's an incredibly powerful carcinogen, so we don't have to worry about that. But UVA and UVB primarily is what causes skin cancer, but UVA also causes skin cancer, is also involved primarily in skin aging, and UVA is the wavelength of light that also passes through glass. and also through significant cloud. So in Ireland, as in any country, be it northern or southern hemisphere, there are different seasons. Although we might feel that there's just one rainy, dreary season here, there is actually, from an ultraviolet point of view, as the Earth turns round and we rotate and the northern hemisphere comes closer to the sun, then we do have varying levels of UV exposure. And these come in a nice pattern here. So in Ireland, really, to be honest, we only get up to maybe 5 or 6. We have occasional levels of 7, but where we need to be worried and concerned about for skin cancer prevention is once the UV light gets to about 3, okay? And what the UV index is the amount of ultraviolet radiation hitting a particular part of Earth at that time. And you'll see now that's built into all the Met Air and the different type of meteorological station broadcasts. They'll give you an idea of the UV index, kind of similar to the pollen index. And we know that the higher the UV count for that day, when it's 3 or above, then we need to be ensuring we have plenty of sunscreen on. So then, who gets skin cancer? So I'm in dermatology now about 20 years, and certainly when I started off, you know, skin cancer, which is largely non-melanoma, so squamous cell and basal cell, that was for the old. The elderly got that. As a young trainee, he said, "Oh, sure, I don't have to worry about that. You know, it's not going to affect me, and it's the elderly who get it. It's the over 65s." Yet there's a problem even in that, because if we look at this, here's a prediction of what's coming down the tracks in 20 years. So in Ireland, 1 in 4 of us will be 65 or above. Okay? So not alone will we have, let's say, our increased risk of heart disease, diabetes, obesity, disuse atrophy or disuse wasting of our muscles, but also we have an increase of skin cancer. So you must be aware of this. This is an enormous health burden that's coming down the tracks. And we know this. We can predict it very well. But the problem is, it's not just the over 65s. I'm not being ageist in any way, but skin cancer is also affecting the under 50s a lot. And this is with regard to non-melanoma skin cancer. So with regard to melanoma, we know that melanoma skin cancer is the highest, from a cancer cause, is the highest cause of mortality, the 4th highest cause of mortality in the under 40s. That's quite sobering. Skin cancer in melanoma has what we call a bimodal instance. So there's 2 peaks, and that is in the 20s to 30s, and then also in the 7th decade, so between the 60s and 70s. So again, when I started 20 years ago, I saw very little non-melanoma skin cancer in the under 40-year-olds. Now I'd say probably 30% of my practice is people 40 or less who are coming into me with both facial and non-facial skin cancers that I'm having to operate on and maybe causing significant surgery and significant scarring and significant psychological burden. And again, a lot of skin cancer is avoidable or can be mitigated against by changes in our behavior, which we'll see coming up. So what are the risk factors for us to get skin cancer? Sun exposure, we know that, particularly intermittent high levels of intense sun exposure, we think in our childhood. That's particularly important. We all remember probably, you know, getting roasted out on Dollymount Strand or whatever, you know, getting thrown out and then getting told to use the calamine lotion. It's good for you to get a bit of skin on you, a bit of color on your skin. But it's not when you're as fair-skinned as we are. An inability to tan. Although we love to think, as Irish, you know, fair-skinned Irish, that we do tan, we don't. That's why we're that fair-skinned. We have evolved, as we'll see in a couple of slides, over thousands of years. We all started off dark-raced from Africa, and then as we came and migrated over millennia, over through Northwest Europe and into then the British Isles and Ireland, we became paler and paler, largely so we could actually produce vitamin D to protect our bones, because there's much less ambient light. So your skin color, people who are very dark-skinned, such as, let's say, Indigenous Australian people or Nigerian people, are that dark-skinned to protect them from the high levels of ambient ultraviolet radiation. Ourselves, we have much lower levels of ambient radiation, so therefore we don't need to be as dark. If we were as dark, we'd end up with severe vitamin D deficiency. So we've evolved to protect ourselves from the lack of sunlight. But that then has led us to the situation where then we are at great risk of skin cancer. Sunbed, or sun lamp use is a real scourge, okay? I'm not going to really get into that here, but that could be another whole talk. But regardless of what the sunbed industry says, and they're really powerful, and I'd have to say admirably successful at how they argue their point, but sunbeds are an incredibly damaging thing, an incredibly important factor in skin cancer development. If we're immunosuppressed, so if we're on other types of medications to stop us maybe from rejecting our kidney transplant, or we're on medication to control our rheumatoid arthritis, or whatever it be, our inflammatory bowel disease, then that does induce a degree of risk for skin cancer. And also if we've had exposure to ionizing radiation. So some of us will have had maybe radiotherapy for various conditions. I have a number of patients who had, believe it or not, radiotherapy for acne back in the 50s and 60s. And then these people have, dozens and dozens of facial skin cancers. That's a cause of them having this risk factor. And then the ultraviolet also sparking off and adding to that risk. So what type of skin type are we? Well, there's a gentleman, he was an Irish-American back in the 30s and 40s, who developed a Fitzpatrick skin type classification. It's not very scientifically rigorous, but it's a good catch-all to give some broad categories of skin type. And it's with regard to how we react and photoadapt. So I'll ask a patient, if I put you in the sun now, would you go red, stay red, go red, then brown, or go brown straight away? That's immediately the first three types, okay? So this is largely, in Ireland, Caucasian Irish are largely one of these two types, whereas Fitzpatrick skin type 1 or 2. But that means that we are those that are at greatest risk of getting skin cancer. So we are the ones then who need to protect ourselves most. If we are Irish but darker skin colored, that's an inherent protection from ultraviolet, and they have a slightly less risk of developing a skin cancer, though it is still possible. So although we all think that we've always been fair-skinned, this is the skull of Cheddar Man. And Cheddar Man was this fossil found from 10,000 years ago in the Cheddar area of Britain. And they did significant DNA analysis and found that actually Cheddar Man, or Cheddar person, I think they did find it is Cheddar Man in this case. Cheddar Man was dark-skinned. Okay? So that just adds weight to this whole hypothesis, which we now believe firmly, that as we traveled over from Africa to Northwest Europe, we were dark-skinned, and then over thousands of years of evolutional benefit, because of the lack of sunlight, we became paler. But now, if you think of the Caucasian Irish population, they're largely like this. And the classical Celtic skin type, very fair-skinned, red hair, very common gene among Irish and Scottish people, that is the skin and hair phenotype. Phenotype is the physical expression of what the gene says, okay? That type of skin and hair type is the type of person who's most at risk of developing a skin cancer, both melanoma and non-melanoma. And that is the type of person who is most important to use regular sunscreen. So how are we doing in Ireland? Well, this is data from the Central Statistics Office. So this isn't me trying to scaremonger as a practicing dermatologist and skin cancer surgeon. This is what's coming down the tracks. So this is us and now, okay? At the moment, with regard to melanoma, there are about between 1,200 and 1,300 new cases of melanoma every year. By 2030, that will have doubled. That is a fact. By 2050, it'll have nearly trebled. Now, this is an enormous problem because we can barely keep up with what we have now. It takes too long to train the likes of me. And then maybe I might decide, I want to retire early. Okay? So the only thing that can, sorry to use this phrase, flatten the curve. I know we're all fed up with it. But the only thing that can potentially flatten the curve is our behavior. And that'll be with regard to our sun exposure behavior over the coming decades. It's even more worrying when we look at non-melanoma skin cancer. At the moment, there are about 12 to 12,500 people who get their first non-melanoma skin cancer every year in Ireland. It's so numerous, non-melanoma skin cancer, that every cancer registry worldwide only counts the first one you get. Problem is, getting a non-melanoma skin cancer is a surrogate clinical marker of how much sun exposure you've had. So when you've had your first one, you have a 40% chance of having your second one within 3 years. You have two, you have 50% chance of having your third one within another 3 years. And once you get above 3 or 4, you can be more or less guaranteed you're going to have them every 2 or 3 years. So this is an enormous, again, health burden on the health ecosystem. How are we going to manage? At the moment, routine basal cell carcinoma waiting list to see me will probably be a year. And then to get it operated on will probably be another year. That's the reality. But we're going to treble the numbers in 20 years. You're not going to be able to treble the number of me. And even if you can, the government won't be able to treble the amount of physical infrastructure. So again, we have to try and flatten this growth curve. Otherwise, this will become utterly unmanageable. And we'll be back to Victorian times, where a basal cell carcinoma was known as a rodent ulcer, because there was such a lack of access to healthcare in those days that by the time the person did get to be seen in the charitable hospital, it was this enormous fungating growth on a person's face. It looked like a rodent had been eating it. And we will get back to that, to a degree, if we can't flatten out this demand curve, because we cannot cope. So, how are we doing in Ireland with regard to melanoma? So we're 11th on this list, okay, just below the UK. But the worrying thing is this. This is European Cancer Registry data. We have the highest predicted male mortality from melanoma in the OECD. Not something to be very proud of. We have the third highest predicted female mortality from melanoma in the OECD. And this is all due to a number of things, but the main thing is access to care. There is a significant degree of maybe patient and population lack of knowledge, shall we say, and lack of awareness. That means that they're slow to, particularly males, because we all think that we're invincible. We're slow to access help, we're slow to access advice, we're slow to admit that there is something wrong. But these mortality figures are largely because the patient who has the skin cancer can't access the dermatologist, the plastic surgeon, the ENT surgeon, the max fac surgeon. Why is this? So the problem with access to care is that, this is particularly with melanoma, the longer you have to wait, then you're using up that safety time zone where the melanoma is totally treatable and totally curable. So in Europe, and most of the time, what you want is that, in Europe, it's about, this is T1, okay? So T1 is when your melanoma is less than, this is a slightly old slide, but it's less than 0.8 millimeters. So 0.8 of a millimeter in thickness, okay? It's a really crucial point. We call it the Breslau thickness, okay? We know that if a melanoma is less than that thickness, then it's utterly curable. And it's really in very rare circumstances that it goes on to cause the demise of a person. But once, and we, unfortunately, it's only in females under 50 in Ireland, is Irish CSO data, that more than 50% of the patient cohort actually is caught at that level when the tumor is totally curable. If we look at the males, it's really quite depressing. you know, particularly you look at maybe the 60s, this is the age group that's most common, melanoma, and you're talking about less than 40% of the patients who are male in this high incidence age group actually have the tumor treated when it's totally curable. So this is not only a human problem, in that this is affecting our fathers and brothers and sons and uncles, but it's also a massive health economic problem. Because now the patient has to go for a sentinel node biopsy. That's maybe a day in a hospital. Then they have to go for CT scans. Then they need to go for radiotherapy. And then maybe they need immunotherapy, which is an amazing drug. These are amazing drugs now. There are people alive now that wouldn't be alive 10 years ago. But they cost 120 grand a patient a year. So again, like everything in health, you know, prevention or mitigation has a tremendous impact, because that means that there'll be more money to go around and we can treat more people. But if we keep catching stuff late, we can only treat a certain number. And the health economics or the Department of Finance will say, listen guys, that's all you can do. So it is beholden on all of us to try and alter our behavior. So that's the first part. Does anyone have any questions? Yes, Matt.
This whole business of awareness of cancer, of skin, of the risks you're talking about. Just as an example, I have a grandchild in Melbourne, Australia, and kids there in school have to have sun hats. I mean, no kid would be without a sun hat. Whereas on a good day in Ireland, when we get a good day, you'll see kids all over the place, and 2- and 3-year-old kids and bare skin, and people say, well, I put on a bit of factor 30 and it'll be grand. But how do we increase the awareness? And people, the message doesn't seem to have got through really with what you see in practice.
It's very difficult. And, you know, there'll be plenty of people, even other medical colleagues, who'll say, oh, Rupert, come on, you're being alarmist. You're just beating the drum just to beef up your own, you know, self-worth, okay? And that could be a fair comment, but the reality is that you have to look at these things with a 20, 30, 40-year outlook. And I think that type of data maybe isn't being presented to people, because what we allow our kids to experience now, even just from the dermatological viewpoint, from their skin exposure, has an impact on them in their 20s, 30s, and later. And maybe that possibly is a way that we may need to make us, I have you 3 young boys, and make us as adults and as parents aware of that, you know, what we do impacts our children. I think it's very difficult to get the adults, get the old dogs, teach them new tricks, you know, but maybe make us aware that, okay, we may not be able to help ourselves or save ourselves, but we may be able to change things for the youth coming forward. And yes, I was talking to a patient there just this week, and they were talking to me about when they did live in Australia and how they had children, and literally the child, if it didn't have its hat and its sunscreen, wouldn't be allowed out in the yard. And that would be it. So it's that regimented. And because the Australian authorities have realized, you know, firstly, I suppose, like evolutionary-wise, white man isn't meant to be living in Australia, you know? So we're in totally the wrong environment. This is an enormous health burden. And this will just keep on happening and worse and worse and worse. So we have to be very proactive in what they do. And I think we probably have to consider that similarly in Ireland, but for the different reason is that we have an incredibly limited health capacity. We must all remember we have 1,800 fewer hospital beds in Dublin now than we had in the early 1980s. We're servicing 800,000 plus more people. We're all living on average 10 years longer. So it is really simple arithmetic. So that might be where, you know, we need to act in the sense that we do not have and we will not have, and the private sector cannot fit that space either, because they're struggling. So we cannot service this demand that's coming down the tracks unless we alter the demand. Okay, so behavioral change. What can we do to lessen our skin cancer risk? So this is Hastings. I trained in Portsmouth and Southampton, and Hastings is a lovely island down off the south coast of England. And this is back in the 1920s. This is in the summer. We couldn't recognize this. People went to the beach, they went for a swim, they went to these huts. Washington Post from the 1920s. This was a regular headline. This is for males who were topless. And they were being arrested. This is modern day. Barely a parasol around. This poor fellow looks like, yeah, he's not going to be feeling too well later on in the day. And interestingly, Noel Coward, the famous English actor and playwright and singer, he had this wonderful phrase, and he came up with the phrase, mad dogs and Englishmen. And if we, just look through it and read it, the natives grieve when the white men leave their huts because they're obviously definitely nuts. Mad dogs and Englishmen go out in the midday sun. The Japanese don't care to. The Chinese wouldn't dare to. So, even in that era, where they sunbathed at the beach in a different manner, but they total disregard to their occupational or daily exposure to ultraviolet. But what should we do? Well, we should know about sun factor, what type of sunscreen to use, and how often to apply it. Really, on the back of your hands and on the face and neck, SPF 50, not 20, 30, there's 20 in my moisturizer, I don't care. It's SPF 50, okay? You got to put it on every day. I kind of say an easy thing from Paddy's Day through to mid-October, regardless of the ambient weather, okay? It's a heavy, cloudy day, you still put it on. 75 to 80% of ultraviolet A still penetrates medium-level cloud, okay? When people say, I got terrible windburn, no, he didn't. He got sunburn, okay? It just came through the cloud, okay? There's no such thing as windburn unless you're up, plus 4,000 meters, okay? And then we need to reapply regularly. That's really every 2 hours after you come out of the bath, after the shower, after you come out of having a good exercise and you're perspiring. And then we do need, though, to be conscious that are there downsides to sunscreen exposure or to usage? Yes, there are. One of them is that we put the sunscreen on, we put on factor 15, like my wife will do, and then think she can sit out for hours. So it's like kind of wearing the scrum cap, Scrum cap's been very useful, but it's only useful really for preventing kind of gouges in your scalp skin. It's not useful, it doesn't give you any protection to your skull, it doesn't mean you can hit that rock faster. SPF is the exact same thing. How SPF is measured, and SPF is just for ultraviolet B wavelength, is it's measured that if you put a 2 mil thick layer on your skin. So SPF 50 really means that if you put a 2 to 3 mil layer of SPF sunscreen on your skin and expose yourself, you'll be 50 minutes, the average person, before you'll start to develop sunburn. It does not mean you can sit out in the sun all day long. So that's why we need to reapply. And we need to know none of us put on that much sunscreen, okay? So the Australians, and this is coming back to your point, they developed this whole thing, slip, slop, slap, slide on a hat and seek the shade. And that's been tremendously successful. And we should seek the shade, again, going back to an old Coward song, between about 12 and 3. Certainly when we're abroad in the Mediterranean or abroad in mainland Europe or in North America, etc. Slip-on clothing, we'll talk about that in a wee minute. There are now, SPF clothing, so ultraviolet protective factor clothing, and a UPF factor of 50 in clothing means that it'll actually absorb 98% of ultraviolet on the covered skin. So it's incredibly powerful, incredibly useful, and also now they're reasonably okay looking as well, okay? And certainly to get your young children into wearing them. And to be honest, if you do it from a young age, they just get used to it. A little 2-year-old just put on them and just, he doesn't know any different. Hat, not a baseball hat, but a wide-brimmed hat, something like a Tilly hat, okay? And the finer and more dense the weave, the better. There's no point in a nice fashionable Panama that you can see the air through. You know, that also the ultraviolet is going to come through that. Sunglasses are important as well. So then this is the star rating for UVA protection for a sunscreen. And really what you want is you want a sunscreen that's at least 4 or 5 star. So you want SPF 50, that's 4 or 5 star UVA protection. We need to be able to understand the UV index, okay? And again, this will be in most Met-Éireann, either digital broadcasts online or even on the radio or on the telly. And in summer, you know, probably from about early May in Ireland, we're into ultraviolet 3, and we get into maybe about 6 on occasion. But from here, we need to be applying sunscreen, okay? I do hear some dermatologists saying you should put on sunscreen every day, all year round. I would kind of disagree with that. Because if you look geography-wise, at our temperate latitude of 53 north, whatever, the incidental angle of the sun in mid-November is only 19 degrees. So we're actually getting very minimal ultraviolet exposure, which is why, again, we've probably evolved to be vitamin D deplete over the winter months. That's probably a normal thing for us. Now, it's probably become so abnormal because now that we get weak bones. But we do need to be careful, particularly if you're sallow-skinned or if you're skin type 4 or above, then you have to be careful. Because although people with skin type 4 and above can burn, they have much less propensity to. But let's say in Britain, where we have some ethnic populations that would have very little sun exposure due to the clothing that they would wear, there's a very significant problem with rickets and vitamin D, severe vitamin D malabsorption and bone problems. We just need to be conscious of that. And indeed, I would probably advocate, and I know another colleague of mine who works in James Patrick Ormond, what we would say to our skin cancer patients is get some early raw sun exposure, maybe before 9 o'clock, after 7, half 7, on your skin for about 15 minutes on your arms. That's enough to convert enough vitamin D to keep you healthy. So there's plenty of clothing that can be used. You don't have to be necessarily look like the French Legionnaire, but you know, this is why they wore. You always had that, you know, saying from your parents, your grandparents, oh, the sun on the back of your neck is very dangerous. You know, we all remember that. But actually, it does cause quite significant sunstroke, and that's why you can wear UPF protective clothing. Again, you know, all of these are available for less than 20 quid in a store in the city, okay? And so the big sports outlets all have these. All of the big sportswear companies have now copped on to this. This is another market for them. Yes, that's absolutely correct, but it's doing a good job. So again, you can get stuff that's very acceptable aesthetically, and it's cheap and it's accessible, and we should be using it. We don't necessarily have to go this far. Any questions? Yeah.
My husband is a delivery driver, and his dad was recently diagnosed with skin cancer, so he's obviously quite concerned about the sun coming through the glass of his vehicle. What would you recommend that he puts on or wears to help him? Obviously, he's coming in and out his vehicle, all types of weather.
Yeah. So I'm assuming it's a right-hand vehicle, right-hand drive. Yeah. And what you will find that people who, let's say, are driving that right by the right-hand drive, there is a greater propensity to right-sided facial cancers. And that's because although the laminated windscreen does absorb most ultraviolet, you're getting very little through there, it's the driver's window that's where they're getting the ultraviolet coming through. So I see plenty of bus drivers, taxi men, delivery men, coachmen. And again, what I say to them that they should be putting on factor 50 SPF on the back of the hands, because up on top of the steering wheel, that's where they're getting lots of exposure. And they should be wearing factor 50 when they're driving as well, you know, and to reapply regularly through the day. A kind of rule of thumb I have for myself, because I don't tan well and I burn very easily, is that once I feel my skin starting to heat up, then I know I need to reapply. And particularly, let's say for someone like your partner, needs to be applying it in the ear, in the what we call the conchal bowl of the ear as well, and in behind the ear. These are all places that we forget about, and up into the hairline as well, and should wear a hat as well, because the hair gives you some protection, but not full protection.
Okay.
Lady in the red. I think there's a mic coming to you there.
Sorry. I suffer from psoriasis, and during the winter it's generally pretty chronic, and I find the only time I get relief is during the summer through sun exposure, and I've noticed that that's tried and tested personally for me a lifetime. So how and I did attend the phototherapy clinic in St. Vincent's Hospital, and they did advise that I warranted treatment, and they said it was several sessions over 10 weeks. And I thought, wonderful, but will the results be long lasting? And they said, not necessarily. So, and I didn't have time to attend, and I said, is it all right to keep up the exposure to the sun, and if necessary, go away during the winter? Because as they explained, the phototherapy centre is set up to mimic the effects of the sun, because we don't get enough in this country. So I thought, okay, I don't burn that easily. I am very worried about skin cancer risks, because elderly relatives of mine have all had melanomas, and I'm trying to balance the two. Sun is the only thing that works for me in the psoriasis, in the resolution of it, and how do I go forward?
So, and I suppose I deal with psoriasis patients as well as skin cancer. I'm very well cognizant of that issue. And you used a great phrase there, how do I balance that risk? And really that's what medicine's about. Whether you're seeing someone with a mild pain, you're giving them a paracetamol, all the time you're making balance, risk-benefit equation analysis. And for yourself, as someone who has significant psoriasis, undoubtedly ultraviolet works very well because anti-inflammatory and it dampens it down. Psoriasis is a tremendous skin dermatosis that has very significant psychological burden. So any relief you get from the ultraviolet is tremendous. There's great improvements in your quality of life. And phototherapy came in probably by the early 70s, and it was largely PUVA, UVA, wavelengths that we used in those days. And we started out and we thought that there's no risk to this at all. This is brilliant, because we didn't know what to do with these. People were in hospital for weeks and weeks on end for psoriasis treatment. Stick them in the light box for phototherapy chamber, and then it all disappeared after 2 or 3 months. And indeed, in the early 80s and mid 80s, there was a penchant for people having maintenance PUVA therapy, and they'd have PUVA twice a week, even when their skin was clear. What we then subsequently found through the 90s was that those patients, particularly those who'd had the maintenance PUVA, ended up with an enormous harvest of skin cancer. So you could, though, predict it. And what we have found now is, whereas before, when I started again 20 years ago, I remember my 2 initial trainers, Paul Collins, Lord rest him, and Sarah Rogers, saying up to maybe 500 exposures of each. 500 times walking into the box. Now we're down to saying maybe 150 exposures combined of either UVA or UVB light therapy. So we've really, we've become much more risk averse because we know the impacts, the long-term impacts of phototherapy. But it is, like phototherapy as is given in a medicated setting, is very well calibrated. The machines are calibrated on a monthly basis. It's all dose related and how your skin responds, whether you burn or not. If you're someone who tans up well, your skin cancer risk will be less than if I had phototherapy. So I think the fact that you do tan, I know you're 30 feet away, but you look quite sallow-skinned, so you probably do tan well, and that's good. Do you have a skin cancer risk? There is a small risk, but if you know what to look for and you moderate some of your other exposure, then that can be managed. And then also, I think it does come down to a personal choice as well. And again, I say to patients, my job isn't to tell you what to do. My job is to tell you what you have, what's the menu of choices, treatment choices you have, and then guide you. If I think you're making a really bad choice, I'll tell you that, but I can't stop you from making that choice. So I think for the patients who I have who have psoriasis or eczema, they've had phototherapy or they're on other tablet or injection therapies that can increase up their skin cancer risk, is to say, okay, this does increase up your risk to a degree, but it's giving you much better quality of life. And as long as you're very aware of this and you know what to look for, we can mitigate that and we can deal with it if in the low chance it happens. I think that's what you have to do. You have to, again, that's why I say it's about mitigation of skin cancer, not prevention.
Thank you.
So then awareness of your skin. How do I know if I have a skin cancer? So often it'll be, you know, I say to people with regard to, let's say, a mole, if it's a risky mole or a dangerous mole, we all will develop moles up until about our mid-40s. Usually, most of us, the vast majority, over 90%, will develop the same pattern of moles. But the moles in your arms might be slightly different looking to the moles in your trunk, might be slightly different to the moles in your legs. But each body site, the moles will generally look similar. The key is, if you're developing a new mole or a changing existing mole that suddenly looks like the ugly duckling, it's a really important clinical sign for both the patient to be aware of and the doctor to be cognizant of. That's the one you want to bring to your doctor. Okay? There are a very small subset of the population who have no pattern and it's all crazy looking, all their moles, but they generally go for regular checks with their dermatologist anyway. With regard to a squamous cell carcinoma, which we'll come on to, is something that's rapidly growing and often bleeding. With the basal cell carcinoma, 85% of them are in the head and neck area because that sticks out, gets most of the sun, and it's usually a persisting non-healing area. So if you look at basal cell carcinoma, this is often what it looks like. Okay? This is a classical rodent ulcer, small, but it has this rim, it's on the head and neck area, it has this raised rim. It's slightly pearly. I know it's a bit of overexposure there, so it maybe doesn't come up as well, but it's slightly pearlescent, okay? And it's often solitary. But it can look like this, okay? Again, well-defined. I see these really quite pretty little blood vessels, okay? There are little telangiectatic blood vessels over it. Again, it's on the head and neck area. This is a basal cell carcinoma. This needs to be looked at. This would grow over years, okay? Start off very small and then gradually keep on getting better, not healing, not responding to the creams you're getting. But it can look like this, which can be much harder for the patient to realize. And they might think, oh God, I had that at 8 years and I just didn't realize until it started to bleed. That's unfortunate. You just can get sometimes these basal cell carcinomas that are scar-like. We call this morphic or scar-like. And often then the extent of this, it probably actually goes up to here, you know, down here. See the slightly paler skin here? This actually will probably be tumor as well. Okay? Or you can be really, you know, unfortunate and have a real scar-like basal cell. This is the basal cell here. Again, this man has had this for 10 years. Very common story. Oh, I just thought it was a sore that wasn't going away. It wasn't causing me any pain, wasn't causing me any itch, occasionally bled. So I just left it, doc. Okay? But it's just to be aware of. Don't want you to be frightened, I just want you to be aware of things. Sometimes it can have color in it. Okay? There's another basal cell carcinoma. Maybe slightly better here, you can see this pearlescent, this kind of translucent appearance to it, and the pigment of the periphery. Now this was sent in very appropriately as an urgent case because they were wondering could it be a melanoma. It's not, thankfully, it's a pigmented basal cell carcinoma. Problem is that if it gets left, and here's scarring, it breaks down. And then not only does it spread peripherally, but it spreads deep. And then it can, you know, over many years, become attached to underlying muscles and then be problematic to remove. But again, very low risk, very rare that it would spread around the body, totally curable. Okay? But it's just that a lot of them occur in the face, so you want to be onto them early so that you don't have to have that much reconstructive surgery. Another common site, okay, is the eyelid margin, and very ill-defined. I don't put these pictures up to alarm or fantasize, you know, kind of cause fantastical, ooh, wow, look at that. No, it's just to make you aware, okay? So this is, again, how you'll know it on a lower eyelid margin is that you get what we call leukotrichia or anotrichia, is that we have the eyelashes here, and within the area of concern, the eyelash is destroyed. Okay? So if you have a little bump in the eyelid margin and there's no eyelashes present or visible, then that's probably a destructive process. That's most likely a localized skin cancer. Because if it's left too long, it does do this. I've probably seen this about 10 times in my career, but it does do that. So it's not just a small skin cancer that doesn't cause problems. So squamous cell carcinoma, much more rapidly growing, okay? Again, on the head and neck or on the genital area or on the hands and limbs. Usually grows like this, has quite a fleshy base and this then hard center. It looks sometimes like a bit like a volcano. These grow over months. Much higher risk of happening if you have someone who's immunosuppressed, a renal solid organ transplant recipient, a kidney transplant recipient on medication. These are the areas that classically it affects. And this is the classical appearance, a fleshy base with this kind of hard center. You'll often see it maybe on the top of men who have propecia, so kind of lack of scalp hair, okay? The scalp, particularly in men who have thinning hair, needs to be protected because it just does not bear the insult of ultraviolet very well. Squamous cell carcinomas can also occur in areas of chronic wounds. So in a burns victim has had lots of skin grafting, they can, 20 years on, develop these sores within the area of scarring or grafting as something to be aware of. And then classically, you can have this what we call cutaneous horn. It looks like little horn coming from the skin. Again, that's a squamous cell carcinoma. Other areas to be of note are on the lip, okay? And often, so you can just get a little bit of dryness and a bit of irritation on the lip, and that's fine. It's just called actinocheilitis. But you can get then tumors. This is painful, sore, bleeding, has been present for about 18 months, getting bigger and bigger. And then this is difficult because we need to remove all that section of lip, and there's a much higher risk of this actually metastasizing, so going to local regional lymph nodes, about a 14% risk, a 1 in 8 risk. Similarly, squamous cell carcinoma on the ear. Ear has a tremendous blood supply, a higher metastatic potential rate. Basal cell carcinoma, you can more or less say it doesn't metastasize. Let's leave it 20, 30 years. And that's only a certain subset of people do that. But squamous cell carcinoma of the ear and lip, much higher risk of it spreading to the local lymph nodes, which then would need a lymph node dissection. This is a man who I operated on. He had a well differentiated, so a low risk squamous cell carcinoma. Came back 2 years later, although it was fully out, again, just at a microscopic level, came back. So squames do cause problems. This is a prosthetic ear. He's a man who works in the agricultural industry. He's lost his ear to squamous cell carcinoma, and about 2 years ago, he lost his nose. Okay? Again, lovely man, come to me for years, but trying to get him to use sunscreen is just terribly difficult. So skin cancer, if left unchecked, can cause problems. So melanoma, what to look for? So A, B, C, D, E, okay? Asymmetry in the mole. Is the border irregular, like eaten away, moth-eaten, okay? Does it have more than 2 colors? Is it greater than 6 millimeters in diameter? And is it expanding? What do we mean by all that? So this is a young lady. She's in her mid-20s, and this is melanoma. And she's had some bed usage, and this is what I mean by asymmetry. So asymmetry in both appearance, physical appearance, and in color, okay? So the way I say to the registrars is if I cut it this way or cut it this way, do each halves mirror each other? And we can see here, they don't. I cut this way, this is different, okay? So this is asymmetric. Border. We look down here. Kind of a scalloped border, okay? So this is an irregular border. This also has more than 2 colors. And when we use a thing called dermatoscope, it has other little features which the doctor will be able to see. More than 2 colors. Stands out. This stood out on this person's skin. They had nothing else that looked like this. And then expanding. This is more than 6 millimeters in diameter, and it's expanding, and it has a moth-eaten border, and it's asymmetric. This is everything. So this is definitely melanoma. Okay? And on the Our Skin Foundation website, which I have to congratulate Our Skin Foundation, especially to Michelle's and David and everyone involved in it, and Ken chairing it and president of it now. This is a wonderful health education resource and information resource. Really, really is. It's top notch. And on this, they have kind of lots of information for the patient. And here, these are just highlighting the differences. This is benign. You can see what they mean by asymmetry. You can see what they mean by border irregularity compared to this. See what they mean by color variations compared to this, and diameter and expanding. Okay? So irishskin.ie, there's lots of really, really good patient information just about what skin diseases are, particularly skin cancer, and how you can mitigate, not prevent, but mitigate your likelihood of developing. So what are the different types of melanoma? There are different types of melanoma with potentially different prognostic risks. The most common is superficial spreading melanoma, makes up about 70% of melanoma. Then nodular melanoma is much more rapidly growing, makes up about 10%. Then lentigo maligna melanoma is a melanoma that we more commonly see in those over 65, and it grows as a melanoma out of an underlying lentigo maligna, which we'll see in a minute. And lentigo maligna is a superficial melanoma that's just sitting on the surface of the skin without putting a root in. And it's often there for years and years and years. It's like the sunspot, except it's growing, and it's maybe becoming darker in areas. And then acral lentiginous melanoma is melanoma on your acral, so on your fingers or toes. Amelanotic melanoma, this is the one that keeps all the dermatologists and plastic surgeons et al. Up at night. So these have no pigment in them clinically. They might look pink or red. They're very easy to miss. They're difficult for the patient to spot. Okay? They have a higher mortality rate because usually the diagnosis is made later because they just don't look like a melanoma. So, classical superficial spreading melanoma, okay. The border is just a little bit notched there, but otherwise it's a reasonable border, but it just stands out. It's more than 6 millimeters. By the history and the story, the patient says, yeah, this has trebled in size over the last 18 months. It wasn't there before. Came out of an ordinary looking mole. Again, different colors. Nodular melanoma, fast growing. All of this brown around here, that's melanoma too. Elderly patient, I remember this patient well. She was about 93. And this underlying brown, okay, that's the lentigo maligna. And then she developed an invasive tumor within that. That's lentigo maligna melanoma. And this is our big frightener, the melanotic melanoma. We always say a mole that becomes red, beware. Okay? Now, all of us, me included, when I get a bit of sun exposure on my forearms, my moles swell up a little bit, become a little bit red, irritated, itchy. That's normal response to ultraviolet. That's the pigment cell within the mole becoming enlarged and more numerous and inflamed. But that'll settle down 3 or 4 weeks after the sunlight exposure stops. So this, amelanotic, and again, it's all about the history. Yeah, this trebled in size, wasn't there before, has come up quickly over a number of months. Okay, that's an amelanotic melanoma. Then lentigo maligna. Lentigo maligna, this is a gentleman in his 70s. Again, this brown patch. People say, oh yeah, that's your sunspot, Dick, But actually, there's all these different colors within it. Okay, that was a lentigo maligna. But it can be subtle. This is in a lady in her late 60s. And she said, there's nothing like that. I don't want you to biopsy that. I said, I want to biopsy it. We had a bit of to and fro about this. That's lentigo maligna, early melanoma as well. Okay? How I knew and suspicious it was because she had confirmed to me, that's probably doubled in size over the last 3 years, Doc, yeah. She's 65 at the time of her life. And I say this to the registrars. I was doing my skin cancer clinic yesterday, and I said the same thing to the registrars. Came out and said, I don't want to biopsy. I said, no, I do want to biopsy that. Because they're 72, at the time of our life when everything's beginning to slow down, biologically stuff is becoming less active. So why is that thing on the skin becoming more active? That means it's biologically active. So we have to sample it. Now, a lot of the time it turns out just it's an irritated, benign sunspot. That's perfect. But you catch lots and lots of early melanomas if you have that. Just that logical way of dealing with and thinking about it. Then acral melanoma, I don't need to tell you, that's somewhere around there. That's obvious. Okay? This is linear melanonychia. Okay? Linear melanonychia is a normal ethnic variant in Orientals, in people from Caribbean, in people from Middle East, and even some Southern Mediterranean ethnic races. It is not a normal ethnic normality in Caucasians. Even so, 7% of Caucasians will develop it, okay? But if you have someone who has this, they're not on, some medications can cause it, but they're not on any of that, haven't had any trauma, then this has to be sampled. Excuse me. How you sample it is you cut here and here, lift the nail, and just, you see the nail matrix back here, and you sample that. But acral melanoma can be more difficult to spot. All three cases are patients of mine in Newcastle. And all three of them, and again, apologies, I've not been to pick on any profession, so apologies if there's anyone in the audience. All three of them went to their podiatrist regularly for anything from 2 to 4 years with each of these, okay? And they were treated as calluses, corns, whatever else, had repeated scrapings and God knows whatever else. But these were always melanoma, okay? You just need a high level of suspicion. They're melanoma because we have a destructive process, okay, that's taken out the nail plate totally. That's not normal. That's not fungus. Or the melanoma here. Again, destructive process. See this pigment? That's melanoma. Or here, the two satellite areas. This poor man had this for 4 years. He lived another 2. Okay? So you don't keep going to someone with a problem that's not getting any better. If you have a problem that's not getting better with the treatment that's being offered to you, you get another opinion. Questions? Yes. I think the mic will come over to you.
I have a quick question in relation to sun cream. I've heard that once sun cream is opened, it has to be used within a certain amount of time. And if you have a sun cream like in your house from last summer, do not use it this summer because it'll be less effective. Is that true?
Yes and no. It is certainly true that there is a chemical expiry date, Now, again, if I owned a sunscreen manufacturing facility, I'd make sure that I didn't push that to the very end because I don't want to open myself to a legal writ, say that people are using out-of-date sunscreen. So undoubtedly some of its chemical activity doesn't just drop off a cliff. And it will fade, kind of like radiation, radioactivity fades with time. Same thing with chemical activity. There's not that many chemical things that will just stop acting just immediately. So with the sunscreens, a lot of it is, let's say, it's a chemical barrier sometimes, or it can, the efficacy of it will degrade with time and deteriorate with time. So my advice would be, it's preferable that you would have a new sunscreen, and to be honest, you'll need more than one sunscreen for the summer season anyway. But if you don't have anything and you can't access it, well then it's better than nothing to use it until you can access a new tube. Yes, Pat. Yeah.
So, what role can GPs play in all this? Because, that'll be the first protocol, obviously, for people.
Well, the first protocol should be the GP, okay? And the GP, general practice, I always say, is the most difficult job in medicine because you're having to deal with everything. With all due respect, lots of the stuff and lots of the patients who go into the GP, there's not a lot wrong with them. And they're trying to filter then sometimes the very vague symptoms of a person who has something serious wrong with them, but it sounds very like just, the other person who has nothing wrong with them. They just, they're worried well. And so it's an incredibly difficult job for the GP to filter accurately those people. The other problem is that at both undergraduate and postgraduate level, the amount of dermatological training that the general practitioner gets is really very small, So the GP is being put in a very invidious position where he or she is being asked to be the gatekeeper without being given the tools to recognize what they should be looking for. And like anything in life, there are those who are really interested, and they're always the ones who come to all the lectures. And the ones who aren't very interested and don't know an awful lot, they're the ones who don't attend the lectures. So it is difficult, and I think it's compounded by the fact that currently the way a referral is made is a prosaic letter of referral. And so then that referral comes into me, and I look at it, and I've got to decide, okay, well, the way they've described that sounds like it's normal. So, routine, 4 years. The way they've described it, oh, yeah, that sounds really worrying. Okay, I bring them in a couple of months. Jesus, I know Dr. X now. He keeps on pulling that trick, just trying to, he overemphasizes the symptoms just to get his patient seen quickly. No, 6 months. So there's this constant discorrelation between what the GP, really difficult job for him or her, is trying to describe in words what they're seeing in front of them. And they may or may not know what they're seeing in front of them. So I think for the patient then, the patient's going, oh my God, what do I do now? The patient, I advise, is if you have something that's non-healing, that looks odd, and it keeps on causing problems, you've gone to GP, he or she said, oh, that's grand, you're okay, don't worry, but still causing you a problem, go back again. They'll probably then refer you. If you're not getting seen by the time you need to, then you ask the GP to try and ring forward. Much better is if you ask the GP to take a really high-quality, focused photograph, preferably 2 or 3 of them, and send that in with the referral. Now I can see, I'm not even going to bother reading what the GP's written. I'm just going to look at the photograph. And for lesional and even for inflammatory dermatology, that's incredibly powerful. So now I can go, oh yeah, listen, Tommy, Tommy's neurotic, and actually there's nothing wrong with that. That's an age spot. I actually don't need to see him at all. Listen, this is just a cream you give him, or just reassure him, okay? Now, Bill, he never goes to the doctor, and he thinks there's nothing wrong with this, but the doctor's taking a really good photograph. That's a definite melanoma. Get him in here next week. So I do think that if you have something that you're really worried about lesionally, take a good photograph, send it into your GP. It'll be really helpful to your GP. And if they're not sure, then you can ask them to send that photograph on with the referral.
And just finally, would it be something you take with your phone, or are you talking about a specialist?
No, you just need a photograph. The one difficulty is, I'd probably say you need to, just with the way the current system is in most of the hospitals, you need to print that off on good color photographic paper. The amount of times I get photographs sent from really good colleagues in community care or patients, beautiful, really high quality photographs, and then someone in the department has printed off in black and white. There's no damn use to me, So maybe print it off in color, give it to the doctor, say, listen, will you attach that and send it on? And then you need to ring the department, say, listen, I'm Rupert Barry, referral went in, there was a letter, there was a photograph attached. Did the photograph get to you? And they said, no, we never got the photograph. Then send it again. I know this is incredibly difficult for the patient, but unfortunately, the system is so overwhelmed that there is a degree of personal responsibility. You need to say, I want to get myself sorted out. So I'm going to make sure that Dr. Jane, she gets to see that photograph, and she gets to see that referral, and she gets the referral. I think you just keep on pushing.
Okay, thank you.
Right, and then I know, oh, sorry, the lady there.
and I was advised to start using sun protection factor 50. So how many months a year should I use it on my face and body?
Now, you are going to get differing opinion on that, okay? But the reality is, with regard to the amount of ambient ultraviolet exposure we have in Ireland, at this latitude, as I said, you need to be using factor 50. You know, if it's very bright sunny weather in mid-February, from then, what I kind of say, Paddy's Day through to the end of October, every day.
Okay, thank you.
And the other thing is, like, biologics, they have totally radically altered, you know, psoriatic arthritis and vastly improved patients' quality of life. The risk of skin cancer to you from them is really very, very small. Okay.
Thanks.
So, last thing then, just very quickly, make an early appointment to see a doctor. How can I help myself? Okay, coming back to your point, you know. This is a chap who, Frederick Bernard, very well known for being an illustrator of the household edition of Charles Dickens, and he was an illustrator. And he's the man who's kind of accredited with this, which is really a paraphrasing of Henrik Ibsen's 1,000 good words, you know, don't even merit one good deed, or a good deed is worth 1,000 good words. But here, a picture is worth 1,000 words, okay? But these are no good pictures, okay? So it's just coming back nicely, maybe tying into what we were talking about. Blurred, shadowed. The interesting thing about this one is, it was sent to me by a colleague in primary care who I know very well. He does lots of skin. He's really, really enthusiastic. And he said, and on the letter refer, he said, Rupert, you'll know exactly what I mean when I send you the letter. I was going, I don't even know whereabouts in the body it is. Okay? So, and I can't make head nor tail of that. So it has to be a good in-focus photo. Okay? Lastly, to paraphrase William J. Mayo, he's one of the 7 founders of the Mayo Clinic. You know, the aim of medicine is to prevent disease and prolong life. And the ideal of medicine is to eliminate the need of a physician. Well, going away from this with regard to skin cancer, the aim of someone like me is to prevent skin cancer and treat it. But the ideal is that you don't need the likes of me. But really, the most powerful thing you can do, and the only way you can ensure you don't need the likes of me, is by flattening that curve and altering our behavior. Thank you very much.